All attendees are in listen-only mode.
Good morning. Welcome to this webinar. This webinar will be on the quantification of health commodities, the RMNCH supplement, RMNCH, Reproductive, Maternal, Neonatal, and Child Health Supplement. It's 9 o'clock in Lima, 10 o'clock in Washington, D.C. People are still showing up. So let's give people a couple more minutes before we officially start this webinar. Bear with me for a couple more minutes because I'm seeing people just arrive into the webinar. 2 more minutes and we'll start. We're waiting 2 more minutes as attendees are still coming in. So please be a little patient. Bear with us for 2 more minutes. Good morning. Welcome to this webinar on the quantification of health commodities, reproductive, maternal, neonatal, child health supplement. This webinar has been organized under the auspices of the Maternal Health Supplies Caucus of the Reproductive Health Supplies Coalition. As you know, the Maternal Health Caucus focuses on 3 life-saving commodities: misoprostol, magnesium sulfate, and oxytocin. Today we're going to be discussing the technical production that was created under the auspices of the UN Commission on Life-Saving Commodities, the Supply Chain Technical Resource Team, or Supply Chain TRT. This TRT developed a quantification supplement that covers 13 underused reproductive, maternal, neonatal, and child commodities. Today we have the honor of having 2 great panelists: Jane Briggs, Principal Technical Advisor at Management Sciences for Health, where she leads the maternal and child health portfolio of the SciAps project. And we have Jane Feinberg, a Senior Technical Advisor with John Snow Incorporated Center for Health Logistics. Both of these ladies will be leading the webinar. You have all been muted in order to avoid background noise. However, please write down your questions. In your screen, you will see a window where it says questions. Once the presentation ends, both Jane Briggs and Jane Feinberg will be answering these questions as they show up in the screen. This webinar is being recorded and both the video and audio of this seminar will be uploaded in the RHSC YouTube channel. I will send out an email with a link to the recording in a couple days. I've been also told that there is a French recording of this webinar available at the UN Commission of Life-Saving Commodities website. I will also send out that information with the recording of this webinar. Please do not hesitate to contact me through the chat window if you have any technical difficulties. I repeat, you all have been muted, and to improve the webinar experience, please make sure you have headphones and that you have closed all your programs so that you have enough internet bandwidth. With no more delay, let me pass the microphone to our presenters. Jane?
Thank you, Milka, and welcome to everybody to our webinar on estimating the commodity needs for RMNCH commodities at the country level. As Milka said, there's two of us that will be presenting. I'm Jane Briggs from the SciAps program of MSH. I'm going to start, and then I'll pass over to the other Jane, and we'll alternate during the presentation. And then we hope to finish the presentation with enough time to allow for questions. And you can type the questions into the question panel during the presentation, and we'll try to address those all at the end. So this is the outline for the presentation. First of all, we're going to look at what the UN Commission was. The UN Commission was the support mechanism for developing this supplement that we're going to present during this webinar. We're going to review the 13 life-saving commodities for maternal health, family planning, and newborn and child health. We're going to define what quantification is for those who are not so familiar with the term, and that it's broken into two steps, forecasting and supply planning. And for the purpose of this webinar, we're going to focus on the forecasting part, which is also what the RMNCH quantification supplement focuses on. We're then going to go through the supplement itself so that you're familiar with the content of it. Not that we want to turn you all into quantification experts, but basically so that you can see what's included in it, what a good resource it is, and then you can share it with colleagues in country that will find this useful for their own quantification exercises. And then finally we'll go through an example of forecasting for the product chlorhexidine. So moving on, what was the Commission? For those that aren't familiar, it was an effort under the Every Woman, Every Child initiative, which was driven by various UN agencies. And the idea was to raise the profile and to generate and share knowledge about 13 underused health commodities with great life-saving potential for women and children. As Milka mentioned, the Commission consisted of several technical reference teams, and these technical reference teams were to target the different recommendations that the Commission had generated and also the different product groups. One of the reference teams that Milka mentioned was indeed the supply chain team, which was to target recommendation 6, was to improve the supply and availability of life-saving commodities. And it had this specific objective that by 2015 all Every Woman, Every Child countries would have improved the supply of life-saving commodities using best practices in information and communication technology. But in order to improve the availability, first of all, we had to identify what the bottlenecks were in the supply chain, and these were the bottlenecks that were identified. And we're all familiar with these. We run into these in our different contexts, and you can see that poor commodity forecasting was one of those bottlenecks. And so all the partners in the supply chain, TRT, worked together to develop this RMNCH quantification supplement that we're going to present today. And this presentation, it's important to note, is being made on behalf of all those partners that were involved in that process. So let's take a look at what the 13 commodities were that were prioritized by the Commission. Obviously, as Milka said, this webinar has been organized by the Maternal Health Supplies Caucus, but we do want to present this in the context of all of the RMNCH commodities that were focused under the Commission. So the Commission identified 13 overlooked, low-cost, high-impact products which could save the lives of more than 6 million women and children every year if they were available and used appropriately. Now, some of these products are new and being introduced. Others have been used for years and are underutilized or not available. But all of them are necessary to save women and children's lives. So the first group we have is for family planning. You have the emergency contraceptive pills, female condoms, contraceptive implants. The next group is maternal health products. So there we have oxytocin and misoprostol for preventing or treating postpartum hemorrhage, and magnesium sulfate for eclampsia and severe preeclampsia in pregnancy. We have the child health commodities with ORS and zinc for diarrhea and amoxicillin dispersible tablets for pneumonia. And finally, the newborn health commodities. So there we have antenatal corticosteroids for respiratory distress syndrome for preterm babies, chlorhexidine for newborn cord care, injectable antibiotics for newborn sepsis, and resuscitation equipment for newborn asphyxia. Now I'm going to pause here and let Jane Feinberg take over for the next piece of the presentation.
Thanks, Jane and Milka. This is Jane Feinberg from JSI. So I'm just going to continue with our presentation here, and I just need to advance the slide. Here we go. So the RMNCH quantification supplement, to avoid confusion, I would like to share some of the definitions that we used in the RMNCH quantification supplement. And these definitions are consistent with other key quantification guidance, and these particular definitions resulted from an exercise to harmonize terms among the members of the supply chain technical reference team that Jane was talking about. So what is quantification? Quantification is the process of estimating the quantities and costs of the products required for a specific health program or service, and judging when the product should be delivered to ensure an uninterrupted supply for the program. And as Jane Briggs mentioned, quantification is made up of two main steps: forecasting and supply planning. We define forecasting as estimating how much product users will require in the forecast period, or how much product the program will dispense to users. And supply planning is determining when and in what quantity those products should be delivered to prevent interruptions in supply. So the supply planning step takes the forecast estimate of quantities of product expected to be dispensed to users, and then takes into account how much stock may already be on hand, how much may already be on order, and what inventory levels the country manages to determine when and in what quantities new shipments need to arrive in order for the entire supply chain to meet the forecast needs. The RMNCH quantification supplement focuses on the forecasting step, in particular related to specific challenges in forecasting commodity needs for new or underused products. The supply planning process is covered quite extensively in the general quantification guide, which we'll mention, and so it's not duplicated in the quantification supplement. So overall, this is a diagram of the quantification process. It's on page 18 of the RMNCH supplement. And you can see the RMNCH supplement focuses on these two steps in the top right corner that I've just outlined in yellow, the preparation and forecasting steps. And as I mentioned, we refer to the RMNCH quantification supplement as a supplement because it focuses on one forecasting method for these 13 products. There are many forecasting methods that a quantification team could undertake, and the main quantification guide covers these as well as supply planning. So we focused on the method that we think in the new and underused product context is the most relevant. So, what are the types of data that we could use for estimating the quantities of product needed to meet client needs? Consumption data are considered the gold standard for stable and mature programs because when they're accurate and complete, they reflect actual consumption of products delivered by the system. These are the quantities of products dispensed or used by clients over a specific period of time. So consumption data already reflects the capacity of the system to deliver a product and the demand that was there for that product. And these data come from a logistics management information system, also known as an LMIS. Another type of data that can be used as a basis for a forecast or estimate of future consumption are services data. And services data reflect the number of services provided or the number of visits where clients were treated or referred over a specific time. Services data are captured in health management information systems, or HMIS, and as I said, tally the numbers of visits of different types or services of different types provided at a health facility or by a health worker. And then assuming a standard quantity of a health commodity is dispensed for each visit type or service type, you can convert from numbers of visits to quantities of product needed. Finally, another type of data that can be used as the basis for a forecast are demographic data or morbidity data. That is data on the number and characteristics of the population targeted for services over a specified period of time, or data on the prevalence or incidence of a disease or health condition in a specific population. These data usually come from surveys or studies. They describe how many people or cases use or need a service. And then to convert to quantities of product, you use estimates of quantities of product needed per person or per case. Ideally, when you're carrying out a commodity forecast, you have multiple types of reliable, timely data available on which to base separate forecasts, which you then can compare to validate or triangulate and come up with a final forecast. So I just said that ideally you would do multiple forecasts based on different data or methodologies. But because these recommended 13 products are new or have been overlooked or underused in many countries, this isn't always possible. Because the products are new or being scaled up, there may not be consumption or services data available for them. Even if there are consumption or services data available, these historical data may not really help understand future need. Related, sometimes countries use last year's procurement as basis for this year's without always knowing whether the amounts of medicines currently available are sufficient, in particular if a program is newly introducing the product or scaling it up. So this lack of available or indicative logistics, consumption or services data is the main reason that the RMNCH quantification supplement focuses on demographic and morbidity-based forecasting. And regardless, you always want to use the most reliable recent data you have available. Another challenge is that in many countries, we don't have country-specific morbidity or incidence data for every health condition. So sometimes we need to use global estimates or refer to regional trends. Also, many times programs have ambitious plans for scaling up a new service or offering of a new commodity, and these can be reflected in data on how quickly scale-up targets for a service will be reached, or how quickly and broadly new service providers will be trained. Of course, we all want to be ambitious, especially about providing low-cost, high-impact, life-saving commodities, but quantification teams need to be very realistic when incorporating program plans into the data they'll use in a forecast. Finally, another challenge that may be compounded in the new and underused product situation is sometimes there's a lack of coordination or information sharing between technical program and departments responsible for procurement. And so our suggestion here, not only for this reason, is for quantification exercises to convene a multi-stakeholder team, particularly for the forecasting step, so that people with knowledge of the programs, the scale-up plans, the commodity management practices, the procurement options, etc., can reach consensus on the various assumptions needed in the forecasting step when determining how much product they think clients will require in the forecast period. So, what is in the RMNCH quantification supplement? Here's a picture of it on the right-hand side of your screen. There's an overall introduction section. The bulk of the content is in section 2, forecasting algorithms for each of the products, and then there's a third section on resources and tools. And we developed this document, this RMNCH supplement, in the context of the challenges that we've mentioned to help program managers, service providers, and technical experts manage the process of estimating commodities needed and to try and help address some of the gaps in data. So it offers detailed guidance on best practice, demographic, and morbidity-based forecasting methodologies in order to improve the quality of national-level forecasts of life-saving commodities when consumption and services data aren't available or aren't indicative. As we've mentioned, this document serves as a supplement to and should be used in conjunction with quantification of health commodities, a guide to forecasting and supply planning for procurement, and a new update of that document here at the bottom in the middle of your screen was just produced by JSI. So this RMNCH quantification supplement, it's not meant to provide guidance on managing maternal and child health or family planning programs, and it doesn't offer specific programmatic guidance on selecting or administering the products used in a country. As Jane Briggs mentioned, the RMNCH quantification supplement was produced in consultation with product and program expert members of the UN Commission, technical reference teams, a number of different working groups working not only on supply chain but also experts in each of the different types of commodities. And as noted, it's meant to supplement existing quantification resources that describe additional forecasting methodologies and supply planning more extensively. So I'll just focus for a moment on what's in Section 2, which is where the bulk of the content in the RMNCH quantification supplement is. For each product, there's a section for each product, and it has information and guidance on product description, what indications it's used for, and some other considerations for its use, what types of forecasting data are needed, and some potential sources of those data. It has a description or a conceptual approach to building forecasting assumptions and calculating forecasted consumption using a forecasting algorithm. It discusses incorporating product and program-specific considerations into the forecasting assumptions. And it also, in some cases where relevant, offers information on additional products, consumables, or equipment required to offer the product. I want to emphasize that the algorithms are samples or examples. They really do offer an approach to how a quantification team might think about setting up its assumptions and calculations for estimating quantities of product that will be needed. But in every case, the algorithm and assumptions will need to be adapted for the country context, country policies, and the data available to the country team. I also want to just note that the content of the RMNCH quantification supplement is current as of our last update, which was made in June 2016. But some of the information is dynamic and changing. Some of the WHO recommendations change. Countries may may not adopt these 100%, etc. So, for instance, we learned recently that since we first put this quantification supplement together, we learned that both 1 and 2 rod hormonal contraceptive implants are now on the WHO model essential medicines list. When the Commission first put together its case study, making the case for the Commission in the first place, single rod implants were not on that list, but they are now. So those are some of the types of things that can change, and so in addition to having to adapt the approach and the examples for each country situation, country teams also need to be aware that some of the information may have changed, and they need to collect and review the relevant and up-to-date information for their context. I'll now pass back to Jane Briggs to continue with more information about forecasting.
Thank you, Jane. So I'll continue to go through what's included in the different sections for each product. So within the forecasting algorithm for each product, there are steps set out that need to be followed when forecasting, either using demographic or morbidity data. And within each product-specific section, different aspects or issues that may be particular to that specific product are explained. And so in general terms, these are the 6 steps that are followed when forecasting. First of all, you need to determine the scope of the quantification. And within this, you need to clarify whether the quantification exercise will cover the product needs for all programs, whether it focuses primarily on the public sector or the private sector, for example, and also to think about at which levels in the system the specific product is being used or should be administered, whether it should be used at the community level as well as at facility, for example. The second step is to estimate the target population, which is usually calculated from either census or DHS data, and that provides the numbers of the group that you're quantifying for. So, for example, how many women of reproductive age at risk and needing emergency contraceptives. Step 3 As most of these are new products, we don't have necessarily consumption data on the products, and so you can use either demographic data or disease incidence or prevalence data to give numbers of cases or predict numbers of users of the product within the target population. Step 4 is to determine the product or brand mix. So here we want information about the different brands or formulations that might be used in a specific country by patients for a specific product. And so this is important to make sure that you're quantifying the appropriate portions of different formulations, for example, that might be used in your country context. An example that comes to mind immediately would be, for example, zinc could be used either in dispersible tablet form or syrup form, and those products could be limited to different types of levels of the facility, for example. The 5th step is to look at the source mix, and so here this is to do with where patients receive the product, where they have access to the particular product, whether it's in the private sector or the public sector, and how those outlets are used. And obviously that information is taken within the context of the scope of the quantification that was defined in step 1. And lastly, to estimate the quantity of the product that is needed per user, per year, or whatever the period of forecasting is, or per case if you're using morbidity data. So now we're going to go over a specific example of a product from the supplement. We're going to use chlorhexidine as an illustrative example to show the kind of information that is included in the supplement that's product specific. I know that the webinar is done under the auspices of the Maternal Health Supplies Caucus, and chlorhexidine doesn't really fit into that group, but as we say, the point of this was to expose people to the RMNCH supplement in general, and so this is just an illustrative example. So we know that WHO recommends chlorhexidine application to prevent bacterial infection in newborns. It's an antiseptic for newborn umbilical cord care and cleansing, and here you can see the WHO recommendation. So they recommend that there should be a daily application of chlorhexidine to the umbilical cord stump during the first week of life, and that's recommended for newborns who are born at home in settings with high neonatal mortality. Clean, dry cord care is recommended for newborns born in health facilities and at home in low neonatal mortality settings. However, use of chlorhexidine in these situations may be considered to replace applications of inappropriate or harmful substances, for example cow dung, that can be applied to the cord stump. So there's a very specific recommendation from WHO. And countries obviously can choose to implement this recommendation differently, maybe choosing to apply chlorhexidine to all newborns born at home, for example. So the forecast that a country quantification team will be working on has to follow whatever the country protocol or recommendations are. So let's move on to how we would actually do that forecast. What we've said is that many of these products are new. Chlorhexidine is one such product. It's still new in many countries. And so typically you would be using demographic data for your forecasting exercise. So to forecast the needs using demographic data, you need to estimate first the number of people who would need the product in a certain time period, and then use your treatment guidelines to convert that number of people into the quantity of the product that is required. Now we would suggest that forecasts are conducted annually for a period of maybe 1, 2, or 3 years. And we'll go into this in more detail later. That doesn't mean that you do it for 3 years and then you leave it alone and don't look at it again, but that's typically the period of time that you would be looking at. So going through the steps here that you see on the slide, you would start with the target population, which obviously for chlorhexidine is newborns, and then look at the number of newborns that would be likely to receive chlorhexidine. So for example, its use may be limited to home births, and so you would have an estimate of the number of newborns you would expect, and then you would have to determine the percentage which should receive chlorhexidine according to how it would be distributed, for example. If chlorhexidine is used in home births and distributed through antenatal consultations to pregnant women, you would have to consider the percentage of pregnant women going to those antenatal consultations. So step 3 is to determine how many tubes or bottles of chlorhexidine would be needed per case according to the protocol, the treatment protocol of the country. And then lastly, step 4 is based on the number of people that will be using it and the amount per case. You can calculate the quantity of chlorhexidine that you would need for your specific forecast period. So let's take a look now at the type of data that would be used for chlorhexidine forecasting. This table is taken directly from the supplement. It's actually on page 101 in the English version of the guide. And so here the idea is that we're trying to estimate the number of newborns that would need the product. Now typically demographic and morbidity data come from surveys, sometimes from other studies. So here the first few lines you can see we're looking at total female population, the proportion of pregnant women, those pregnant women attending antenatal consultation, what percentage of births are at home, and what proportion of live births. And so all of this data comes from census data, DHS surveys, specific surveys, or ANC records. So this is where you get the data for those kind of calculations. Then we need to look at how the treatment guidelines are applied. So the dosage that's recommended would come from either WHO or national guidelines, but also you need to consider that actual practice may not necessarily follow those protocols, and so there may be deviations in what's actually being applied. And then lastly, the other type of data you need to bear in mind in the forecasting exercise is what interventions or other factors can affect changes in demand. What programmatic initiatives are going on that would lead to scale-up taking longer, scale-up being faster. For example, is there an effort to increase the proportion of women to give birth at facility versus at home? All those programmatic factors need to be taken into consideration in the forecasting exercise. So moving on, I'm going to show you what a typical algorithm looks like in the supplement. It's a flow chart that takes you through all the different decision steps to calculate at the bottom what proportion, what amount of the product you need. I'm not seeing the slide coming through, so I'm going to hold on a minute until that slide comes through. This algorithm, when it comes up on the slide, is in page 103 for of the supplement, the algorithm specific for chlorhexidine. And it takes you through a number of steps. Okay, so at the top of the slide, we start out with a number of live births. And so then the next decision point is chlorhexidine recommended for home births only or at the facility level? So if it's just for use at home, for home births, you would have the number of live births and the proportion of home deliveries to take you on to the next number. In this scenario, we're saying that there would not be chlorhexidine applied at facility births, so that side of the algorithm is a no. When the next point comes up, Jane, please. And then once you've got your proportion of live births that would be at home, moving on to the next step, we would see the number, you would calculate the number of live births that are likely to receive chlorhexidine. So in the next box that comes up, we'll see the number of live births that are likely to receive chlorhexidine, and then from that you can calculate the amount of chlorhexidine that's required at the bottom, which is obviously the number of live births that are likely to receive chlorhexidine times the amount that you need for each case, for each neonate. And so this is a sample algorithm for the chlorhexidine example that we're using, but there is an algorithm like this with these decision trees for every product that's included in the guide. So now moving on to the chlorhexidine example that is shown in the supplement. For each of the products, a example is laid out of a country, context, example for forecasting, with the numbers in so that people can see how the forecast would be generated. And so now I want to present you the example for chlorhexidine. And so here we have a country X that has recently updated their RMNCH guidelines to include chlorhexidine gel application for all home births as a single application immediately following birth. And so the idea in this country X is that chlorhexidine will be provided to community health workers for distribution to all women who will give birth at home. The number of home births in this country in 2016 was estimated at 10,000. The population growth rate is 2%, and the amount of chlorhexidine required per neonate is 1 tube. And the program expects that, seeing as these guidelines were only recently updated, they expect that there would be a gradual increase in the use of chlorhexidine, and anticipating an increase of 25% each year to achieve 100% coverage by the year 2020. And so the task for the quantification team in this country is to calculate what is the need of chlorhexidine for the current year, 2017, and 2 subsequent forecast years. So this is a fictitious example. This is the data that the quantification team will pull together prior to the quantification exercise, the forecasting exercise. And so then they will put these numbers from this data that they have gathered into their calculations. And so this is a sample table. I'm using that example of how the forecasting exercise would be conducted for chlorhexidine. I will take you through it just so that you can see that it makes sense, but obviously as I'm going to make quantification experts out of all of you, but this is information that's presented in the supplement, so you can see how useful it is for country teams. So here for the current year, 2017, the number of home births was 1,000. Factoring in that 2% growth rate, you can see that the increase in home births is from 10,200 in the first year and goes up for the next 2 forecasting years as well. The program anticipated a 25% increase each year for the utilization of chlorhexidine, so 25% in the first year, 50% in the second year, 75% in the third year. And so working those numbers through, the third line shows the number of neonates that would receive treatment with chlorhexidine using the assumption that there are 10,200 home births and that chlorhexidine would be used in 25% of those. So that gives you 2,550 neonates that would receive chlorhexidine treatment in that first year of 2017. And then that same calculation is applied to the data for years 1 and 2 of the forecast. So you have a total of 3 years forecasted there of the neonates that would receive treatment, and as each neonate would receive 1 tube, that gives you the same numbers for the total amount of chlorhexidine that would be required, given that scenario of utilization. And so you have a total there that would be generated of 15,000 more or less chlorhexidine tubes for those 3 years. Very key here is that all of this is dependent on the assumptions that are made. And so it's very important that the quantification team is realistic in the assumptions that they make. And so those utilization rates, are they realistic? And so the team really needs to make sure that they're applying realistic growth assumptions. And the other thing is to say that, as I mentioned earlier, you don't do a forecast for 3 years and leave it there and pick it up again in 3 years' time. The idea is that you should be reviewing this maybe every 6 months, at least every year, because you have new information on how you're achieving the targets. Was there a utilization increase of 25%? Was it slower? Has funding been delayed coming in? Training hasn't happened? And so all of those things may lead you to adjust these assumptions. And it's said that quantification is more of an art than a science because it's not just a mathematical exercise. You have to be very careful that you're using assumptions that are realistic. So I'm going to hand back to Jane so you have a different voice to listen to for the next few slides as we finish the presentation, and then let's open up for some questions. Thanks, Jane.
Jane. So as Jane was just sharing with us, you know, is the forecast an ending point? We say no, it's part of a continuous process involving stakeholders in the forecast itself, and then certainly validating the assumptions and results with stakeholders increases buy-in for the decisions, the assumptions, and increases buy-in for those calculations that affect how much product is ultimately procured for the program. So once the quantification team agrees on how much product they forecast or estimate will be used or needed in the coming period, it's time to prepare a supply plan and take into account how much product is already in the country or on its way, and how much stock needs to be held at intermediate levels in the supply chain to ensure that commodities are getting to service delivery points and into the hands of clients. As we mentioned, the supply planning step is covered in detail in what we call the main quantification guide, Quantification of Health Commodities, and it's referenced in the annex in the RMNCH quantification supplement, so you can find your way there easily. And then another point to make, especially in the sort of newer underused product context, is that routine pipeline monitoring, something that we would typically recommend take place each month as new information is available on what was used and what remains, that for sure needs to take place, and perhaps with even more care and scrutiny, because in a scale-up situation, there's just more uncertainty. There was more uncertainty in developing the assumptions for the forecast, and so as new data come in, it can be possible to review and revise. And so, as Jane Briggs pointed out, you know, you don't prepare a forecast for 3 years and then just keep buying according to that list. You do need to, as you have new information available, return to the estimates and potentially adjust the forecast. And in the new and underused product context, quantification teams should consider returning to those assumptions and seeing if they have new information that might help them adjust those even more often. Certainly once a year, much better twice a year, even better quarterly, if possible, if new data are available. So here are some countries where quantification teams have used this guide, either this version or a previous version, and given us feedback. That's been incorporated into the version you can access now. We do expect to make some minor updates in the next month or so to the RMNCH quantification supplement. So if, as you are having a look at it, sharing it with colleagues in country, or using it yourself, please do make note of anything you think may need to be improved or updated, and let us know. We'll show our emails here at the end of the webinar. Let us know so that we can try and incorporate any improvements into the updated version that we'll produce in the next few months. Also, we didn't go over it in detail, but there is an annex at the end of the RMNCH quantification supplement with many other resources, links to different documents, reports, and other software tools that may be useful to a quantification team. That's starting on page 156 of the supplement. So I think we'll pause here to take some questions. I think Milka was going to help us by reading questions to us if you've written questions in. If you haven't written questions in, please do so, and we'll take some questions.
Thank you, Jane, both Jane Feinberg and Jane Briggs, for this wonderful presentation. To the right of your screen, you should have a window where it says questions. Please do write your questions. I don't see any questions from before, so if you have any questions, let's start writing them, and I will facilitate this question and answer period. I do have a question for any one of you two. Where has this supplement been applied? What countries have used it for their forecasting exercises.
Thanks, Milka, and luckily I have that slide showing, which is either we or colleagues or other folks that we've heard from have used a previous version of the supplement in the countries listed here: Bangladesh, Cambodia, DR Congo, India, Indonesia, Mozambique, Myanmar, Namibia, Nigeria, and Tanzania. Those are the ones we know of and have heard back from that have used the supplement as part of a quantification exercise. Some of them may only have used it for some guidance with maternal health supplies estimates. Others have used it as part of a family planning quantification or a combined reproductive health, family planning maternal health product quantification. So, you know, not every country manages every product or prepares estimates for every product at the same time, but we've heard at least from colleagues in these countries listed that they've used it, and those folks provided feedback to us for us to make improvements.
And do any of these countries have institutionalized the guide?
For the version that is available now.
Jane, and do any of these countries have institutionalized the guide? I mean, is it the way they will forecast everything they do, or it's been it's not being systematized throughout the whole country?
Thanks, Milka. This is Jane Feinberg. Just to make sure I understand your question, in terms of institutionalizing use of the guide, I'm not sure I can answer that. It's something you know, prepared to make available, useful to them, as we've heard back from with some comments, but we don't have that level of follow-up to know, is it something they're going to use every time they do a quantification? But I hope that there are elements of the approach that are useful.
So thank you so much.
In terms of being used throughout the country, sorry, I think part of your question was being used throughout the country, and really this methodology or conceptual approach is aimed at a national level quantification for a team preparing estimates for a whole country, right? It's not a methodology you apply to estimate what's needed at a single facility or you know, in a single group of facilities. It's really sort of a country-wide or national level estimation technique.
Thank you so much. We now have some questions here for you. Archibald Okota is asking, how do you factor unmet needs in the quantification process?
I'll take this. This is Jane Briggs. I'll start off, and Jane can obviously add to that. I mean, I think that's a very important point, and this is obviously something that is crucial as part of the quantification process. We're not necessarily going to be able to factor in how much that is unless we have an idea of what those unmet needs are. There is actually a resource that is available on estimating unmet needs, and that is available through the Life-Saving Commodities website. We can certainly include a link to that document when we send out information about the recording of this webinar. But I think just for the purpose of time, I mean, this is obviously something that has to be considered in the assumption process as your quantification team is working through their assumptions and looking at what the demand is for services and whether they're being realistic in those and what demand generation type activities need to be included. But I think it's a very important point, and certainly we can share that document with you so you can take a look at that.
I have another question from Andrea Baer from the Williams Davidson Institute. Great presentation, thank you. Are you familiar with related efforts in quantification regarding countries' development of roles, responsibilities, and procedures for quantification, getting at the question of countries needing to have systems in place and well-defined roles for who is doing quantification? I'll repeat the question again. Are you familiar with related efforts in quantification regarding the country's development of roles, responsibilities, and procedures for quantification?
This is Jane Briggs. I'll take a stab at that, and if Jane wants to complement, you can do, Jane. I mean, I think this is a very important piece of quantification, and I think this supplement was aimed to address the technical aspects related to these commodities that are either new or underused, and so the technical focus of that quantification exercise or the forecasting exercise. But the issues that you mentioned are clearly very important, and so that whole kind of transparency, governance side of the quantification process is crucial. That's not touched on in this supplement. The supplement does refer to other documents that talk through quantification, probably more from the sort of mathematical, technical side also, but I think that the components that you're mentioning are very important, and there are resources out there to guide country teams through that. The processes need to be standardized to improve transparency and to ensure that the methodology is applied in a similar way year in, year out, and the review process more frequently. And I think, you know, we mentioned a little bit in the presentation about how it needs to be a multi-stakeholder team, and so all the different teams come with different pieces of information, and so clearly those roles need to be defined through that process. I don't know, Jane, whether you want to add anything to that?
No, that makes sense to me. This particular resource doesn't address, beyond saying that, you know, we recommend that a multi-stakeholder group carry out consensus forecasting, that different groups with knowledge of the program and procurement and supply chain bring their expertise to the table. But certainly, you know, many countries have technical working groups or commodity security committees where they have developed terms of reference, and there are examples of those. The RH Supplies Coalition has some of those as well, examples. Beyond that, Andrea, we can, if you have a follow-up, we can talk about that. But as Jane says, this supplement was meant to address sort of the technical conceptual approach to calculations.
I have another question from Rakam Kamar. There are several options available that are in use by various programs in various countries. To shift to this methodology, it means that they will need to leave what they are presently using. Do they need to leave what they are presently using to use this?
This is Jane Briggs.
Mm-hmm.
This is Jane Briggs. I'll respond to that. The answer is no. The idea is not to force people to change to a different methodology. This was developed as a resource that country teams can use to improve what they're already working on. And if there is a methodology that's already established in country that works well, then that's fine. But I think the idea is to provide this as a resource to country teams to be able to check that they are including all these important pieces of data, that they've considered all these points that are raised in the supplement. So it's an additional resource for teams to use, but it doesn't mean that it should replace what they're doing. But if quantification is being doing correctly, then they should be following similar guidance to this anyway. So it should be sort of checkpoints that they can refer to and include in their methodologies.
Okay, I have another question from Juan Jaramillo, IPPF. You often see that during the forecasting phase there is a calculation for buffer amounts. instead of calculating them at the supply planning stage. How do you handle those situations and the problems, if any, that you have seen from that practice?
Hi, Juan. This is Jane Feinberg. I can have a go at that question regarding estimating a buffer on the forecast amount. I think you're referring to preparing an estimate of projected or future consumption and then adding a buffer kind of just in case. And that may be different than what you say at the supply planning stage, where you build in the quantities that you need to manage in inventory at different levels of the system based on the min and max at each level of the system. So in the in this RMNCH supplement, we don't show or recommend or include in any of the examples any additional buffer at the forecasting stage. Our approach is that the quantification team has to consider what the different indicators it's going to use are and what assumptions about those it will use to come up with the estimates, and quite a bit of uncertainty is obviously involved in coming up with assumptions. They need to be as evidence-based as possible, but of course we noted that that for many of these products there may not be country-specific data on morbidity, or there may not be other historical or survey data specifically for that country. So of course there's always some uncertainty or inaccuracy in a forecast. At best it's an estimate of the future, and you can't know the future for sure. But we don't include in this methodology a recommendation to include a specific buffer over and above, I'm assuming above, the forecast quantity. That said, a quantification team can, as part of its discussion of its assumptions and of the final forecast that they want to use as input to the supply plan, they can say, you know, we're this uncertain and we're worried for X or Y reason that we're underestimating, so we want to add a buffer. But of course, you know, if you add a buffer, you're not sure about that could lead you to overestimate.
I have another question from Cindy Sajek from the Meridian Group. I'm interested to know if there are any guidelines for considering how to incorporate what the commercial sector may be contributing. Sorry, I lost the question. Just a sec. Again, I'm interested to know if there are any guidelines for considering how to incorporate what the commercial sector may be contributing for some of these essential commodities. For example, we know that the private sector markets for emergency contraception are growing quite rapidly in some countries.
Hi, this is Jane Feinberg. In the example or sample algorithm for emergency contraception, just because you mentioned that example, and in the example that Jane Briggs presented, we talk about noting the source of supply for the product. And so we expect that most of the users of this guide, of this quantification supplement, are likely to be looking at public sector provision or public sector and NGO or social marketing provision of products, but certainly there is commercial sector provision of many of the products, and if there's data on that, then you can incorporate that into your forecast. You can say, you know, if we know that a certain proportion of clients or users are accessing their supply of emergency contraception from the commercial sector, you can factor that in the algorithm. And so if you look in the guide at the algorithm for emergency contraception, you'll see a place for, for source mix or source of supply.
Okay. Archibald.
Milka, this is
Sorry, Jane.
This is Jane. I'm just conscious of time, and I just wanted to share the last slide that we have that has where you can see this supplement. And I wonder if now's maybe a good time to sort of have a couple of wrap-up points.
Okay, I have one last question here. I have one last question from Archibald Okota. Consumption data and demographic data, which will be the superior data source in the quantification and why?
Thanks, Archibald. This is Jane Feinberg. As we covered earlier in the presentation, consumption data are considered the gold standard for preparing a forecast because they capture already actual dispensed to user data, and it's already reflected in terms of the product and reflects the capacity of the system to deliver that product to a user. But in the context of new and underused commodities, oftentimes there is no consumption data, or it may not be indicative of the future. The quantification team may not think that it accurately captures what they expect demand to look like in the future because use of the product is being rolled out or scaled up or promoted in a different way. So that's why the RMNCH supplement focuses on demographic and morbidity-based forecasting, though in a stable, more mature health program, consumption data, if those are available are complete, accurate, and up-to-date, those are considered an excellent basis to have for forecast.
So Milka, I think given people's times, I'm sure other people have things to go to. We can't stay on the line all day, which I'm sure we'd love to. There's lots of interesting questions still coming in, but I think we will wrap up now. This is Jane Briggs, in case you didn't catch the British accent there. What we've tried to do today is to share with you a conceptual approach as a reference source for forecasting as an important step in quantification of these health commodities. I think it's important that it isn't just taken as a standalone document. It has to be used in conjunction with other resources, which is expressed in the guide. And also, as I think somebody did ask a comment, is how do you integrate this with other systems? It complements the quantification mechanisms that are already ongoing in country. And so the idea is that by quantification teams using this resource, it will improve their forecasting. To remind them of things they haven't maybe considered, or show examples of these commodities that are either new or underused. And so typically teams are kind of struggling with how to quantify these new commodities. And so we assume that better forecasting will produce obviously better quantification. It helps us with resource mobilization, and ultimately it will improve availability of these life-saving commodities, which we all agree are very important for health outcomes for women and children. We've talked about it being a conceptual approach that is as updated as it is as per the last update, and clearly needs to be revised as global recommendations change. For example, in the case of newborn sepsis, there's changes going on in that field, and also needs to be adapted to country adaptations of global recommendations and the specific country guidelines that are being used. So I think, you know, if people have used this guide and want to share with us how they've used it, we'd love to know how it has been used. I think in Uganda, for example, was a country that wasn't actually listed on our slides. We know that the guide has been used to facilitate the quantification of all essential medicines, not just for the RMNCH, but for a whole quantification exercise. So do let us know if you've used it, if it's helped, and how you think it can be improved, if you think it can be improved. This is a link to where you can find the guide, both in English and in French. If you explore that link a little bit more, you can find the webinars in French and English that have already been conducted, and Milka said that she will circulate the link to this webinar. And thank you very much for joining.
Thank you very much. On behalf of the Maternal Health Supplies Caucus of the RHSC, I thank you all for attending this webinar, and special thanks to both Jane Briggs and Jane Feinberg for making this possible. Have an excellent day. Bye-bye.